Hi everyone, I'm Dr. Ilajan Khandelwal and today I'm here to discuss the pathology questions which were asked in this year, that is 2023 NEET-PG exams, right? Now, if you ask me the overall feedback which I got from students about the exam, they said that they found the exam a bit lengthy and much more clinical, right? So students, that is what we were expecting because we are anticipating that the future exams will be on the next pattern, right? So this is what was expected. But if you ask me the analysis of pathology in this year's exam, a lot of students messaged me that pathology was one subject in which they could answer a lot of questions correctly. Reason being a lot of previous year questions and the previous year topics were asked, right? So if you ask me the overall analysis of pathology in this year's NEET PG, there were around 20 questions with overlaps, right? Mostly clinical stem and correlation. A very important point to take home from this year's exam was there were no questions from general pathology. There was just one question from genetics. That was also a very weird question and Robbins does not give an answer to that. I'll discuss that question in detail in my lecture in future. But the surprising part was there were no questions on general pathology. Now, what I think is that might be because the exam is going on the next pattern, they're not giving the general pathology questions, which are more of ratification or mugging up, right? But then this exam is totally unpredictable. This year, this was the trend that most of the questions were from hematology and systemic pathology, right? The difficulty level in pathology was mild to moderate. There was not a single question which was a bouncer, right? And a very important and interesting thing was mostly repeat topics like Burkitt's lymphoma or owl's eye or AML or rods. So repeat topics and common topics were more commonly asked, right? Now, if I tell you the topic distribution, students, as I've already told you, most questions were from hematology and systemic pathology. In hematology, they covered these important topics. So for your INI-CET and future NEET exam, you have to revise these topics, right? What were the topics? Burkitt's lymphoma. We all know how important is this topic for all MCQ exams, right? Gaucher's disease, image-based question was there. Owl's eye appearance, hemophilia. Hemolytic anemia, hereditary spherocytosis was one question. In leukemias, they asked about CLL and AML. Both were image-based questions. And there was one question from blood transfusion and blood transfusion reaction, right? In systemic pathology, one of the most favorite topic of the examiner is lung cancer, right? So here also there was a question on lung cancer, squamous cell cancer. Then from lung only, there was another question on asbestosis, mesothelioma, right? That is also one of the examiner's favorite topic. From kidney, surprisingly, there were three questions. One, there was a normal histology of glomerulus. Then there were two very direct questions on membranous and post-streptococcal glomerulonephritis, right? Then there was an image-based question on heart. There was a question on polyp, which is one of the examiner's favorite topic from gastrointestinal tract. And lastly, there was a question on prognosis of breast cancer, another very hot topic for the examiner, right? So this was the overall topic distribution. The difficulty level was not much. It was just mild to moderate, right? With these basic details, let us see the questions, right? Now, the first question was, an elderly male with chronic cough, significant weight loss and fatigue. The patient is a known smoker. His serum calcium is raised. Biopsy findings show large atypical cells with hyperchromasia. What is the most likely diagnosis, right? Now, the history of a elderly male with cough, weight loss, smoker and high serum calcium. What do you guys think of, right? The patient definitely has lung cancer, right? Now, what type of lung cancer, that I have to tell, right? Now, because in this patient, there is a history of hypercalcemia. Remember, students, I told you that hypercalcemia is a very important paraneoplastic syndrome in squamous cell carcinoma of lung. Remember a table which I discussed discuss for lung tumors and lung cancers, right? Hypercalcemia is the PNS in SCC. That is why the answer in this question is squamous cell cancer, right? Let us see the other option. One is large cell neuroendocrine tumor. Is this a neuroendocrine tumor? No. Why will it show high serum calcium? It does not show high serum calcium, right? And it will not show large atypical cells with hyperchromasia. If it is a neuroendocrine cancer, what will it show? It will show cells with nuclei having salt and pepper chromatin, right? That's not given. That is why this is not the answer. Small cell cancer, again, male smoker correlates, but the paraneoplastic syndrome or the history which can be given in this patient is that of Cushing syndrome or syndrome of inappropriate ADH secretion, right, but not of hypercalcemia. That is why small cell carcinoma is not the answer. Adenocarcinoma is also not the answer. Why? Because adenocarcinoma is more common in females and adenocarcinoma is more common in non-smokers, right? So, with the history which is given, we exclude this. So, this was a very good clinical question from the favorite topic, that is lung cancer, right? Now, let us see the table which I tell all of you, which is very, very important for all MCQ exams, how to differentiate the various types of lung cancers, right? So, all the points in the history and the biopsy and the clinical points, they can be asked in the question and can be used in a clinico-pathologic scenario, right? So, for squamous cell cancer, males more common than females. Adenocancer is the one which is more common in females. Small cell males more common and large cell males more common than females, right? Now, squamous cell cancer is mostly centrally located. Small cell is also centrally located because it is very poor, very aggressive, it can go to the periphery also, right? Adenocarcinoma is mostly peripherally located and large cell is also mostly peripherally located. This can also be given as a keyword in a clinico-pathologic question. Most of them are smoking associated. The strongest association with cigarette smoking is that of small cell lung cancer. Adenocarcinoma is seen in non-smokers. Another important point, right? Now we come to paraneoplastic syndromes which are given in this patient's history. Squamous cell carcinoma associated with hypercalcemia. Adeno can be associated with migratory thrombophlebitis. Small cell can be associated with Cushing's or SIADH. Large cell can be associated with gynecomastia, right? Then pathogenesis can also be asked in future. SCC associated with P53. Adeno can be associated with KRAS EGFR. Small cell can be associated with LMYC, right? Now, a very important point is the biopsy features, right? Squamous cell carcinoma anywhere in the body shows the presence of keratin pearls and desmosomes. I've already told you, very important point. So, if the biopsy shows keratin pearls and desmosomes, you have to think about squamous cell cancer. Adenocarcinoma shows glands which are lined by pleomorphic cells anywhere in the body, whether it is GIT, rectum, colon, anywhere. Small cell carcinoma will show small cells with salt and pepper chromatin, nuclear molding as a party effect, and large cells will show large pleomorphic cells. Another important point which can be a keyword, student, is the IHC markers, right? SCC is positive for CK, P63 and P40. Adeno is positive for TTF1, that is thyroid transcription factor 1 and apsin A. Small cell cancer is associated with NSC, synaptophysin, chromogranin, CD56. A lot of times in NEET and NICT, we have seen that they use this point, the IHC markers, as an important keyword, right? So, image and IHC is also very important, correct? Let us quickly see the images. See, students, SCC anywhere in the body will show these. What are these? Can you see? They look like pearls. So, these are something which are called as keratin pearls. Desmosomes can only be seen on high power, right? And what will be the history? Males more common than females, smokers, and CK P40, P63 positive. Adenocarcinoma anywhere in the body will show these glandular structures, and these glands are lined by pleomorphic cells. Important three keywords in adenocarcinoma: usually women, peripherally located, non-smoker, right? Next, bronchoalveolar carcinoma is now popularly called as adenocarcinoma in situ, right? And it shows the cells which are arranged around the bronchoalveolar linings, and these cells are also pleomorphic, little pleomorphic, right? The arrangement is called as the filigree pattern or the lepidic pattern or butterflies on a fence. This arrangement is called as a butterflies on a fence. Easy? Next, small cell lung cancer, students, all these points are very important. It will show small cells with salt and pepper chromatin. When you see the chromatin, it is like this, right? Strongly associated with cigarette smoking. It has the worst prognosis. Another important point, right? It is highly chemosensitive. It shows azopardy effect. What is azopardy effect? Azopardy effect is the basophilic staining of the vessel wall. Can you see the vessel wall? This is a blood vessel because you can see RBCs in the lumen. And can you see the vessel wall has become basophilic? Right? It has become basophilic or blue or purple, right? Why? Because of the DNA, the nucleus, right? Azopardy effect done. It shows maximum paraneoplastic syndromes, and the markers which are there are NSC, chromogranin and synaptophysin. Easy? Then students, we have large cell lung cancer. It is usually a diagnosis of exclusion. If you can't fit the cancer into any category, it is large cell lung cancer, shows large highly pleomorphic cells. Then we have a carcinoid tumor. There have been two instances in which the AIMS or the INICT examiner has asked a question on carcinoid tumor, right? So, carcinoid tumor, I have already told you, cells with salt and pepper chromatin, just like small cell carcinoma of lung. In the history, there can be a history of sweating or nausea, any sympathetic stimulation, right? The markers are the same as that of small cell lung cancer, NSE, synaptophysin, chromogranin, correct? So, these are the different lung cancers, which is a very, very important topic for all MCQ exams, right? Now, students, let me quickly revise the questions which were asked in November INICT, because your INICT exam is just 2 months away, right? These were the two questions which were asked in November INICT on lung cancer. An adult male patient presented with shortness of breath, hemoptysis, weight loss. On examination, hilar mass was present. Histopathological image is shown below. Immunohistochemistry revealed that cells were positive for P40. I've already told you the points. The patient has a hilar mass which is P40 positive. Even if you don't know how to diagnose the image, if you think about that table, what will be the diagnosis? Squamous cell carcinoma. And what are these cells showing, students? This is a keratin pearl, right? So, the answer was, in this case, squamous cell cancer. Easy? Next question which was asked in the same INICT exam in the next session was, a chronic smoker with 24 packs of cigarettes presented with breathlessness and chest pain. So, the patient is again a smoker. Whenever the patient is a smoker, you will think about two things, students: squamous cell cancer, or you will think about a small cell lung cancer, right? Lung mass is seen radiologically. On staining, the cells are positive for chromogranin. Now, here the cells are positive for chromogranin. What will you think of? Small cell lung cancer, right? Easy. There it was P40, so answer was SCC. Here it is chromogranin, the answer is small cell lung cancer. Correct? Next, another question. A chronic smoker presents with a lesion in the lung. A mass is noted at the lower lobe periphery of the lung. Diagnosis of lung adenocarcinoma is made. Biopsy will be positive for. Now, it's a reverse question. They are not asking you the diagnosis. They have told you the diagnosis is adenocarcinoma. What will be the marker? I have told you two markers for adeno, TTF1 and napsin A. So, what is the answer, students? The answer is TTF1 and napsin A. This was a multiple choice question. So, these two were the answer. P40 will be positive in SCC, chromogranin will be positive in small cell cancer, right? So these were the questions which were asked in the INICET exam in November last year. Easy, students? So lung cancer, a very, very potential topic. You should know this topic inside out along with images and markers, right? Let us move to the next question now. A child presented with cola colored urine and hypertension along with puffiness of eyes. Now, if I get this history, students, just this line, let us mark the keyword. A child with cola colored urine, hypertension and puffiness of eyes. I know that my patient has a kidney problem, and because there is puffiness of eyes and hypertension along with cola colored urine in a child, what will you think of? Won't you think of post-streptococcal glomerulonephritis? Yes or no? Yes, right? Creatinine was 2.5. Treatment was started, and despite treatment, patient did not improve for the next 3 weeks, right? Creatinine increased to 4.5. What is the electron microscopic finding in this case? Now, I think that this was a very simple and a good clinico-pathologic questions. A lot of students messaged me that, ma'am, we really got confused in this question. I'll tell you why you people got confused. See, with this history, I have made a simple diagnosis that my patient has got PSGN. You all know that PSGN usually occurs in children 5 to 15 years of age. Clinically, the patient has cola-colored urine and it presents with nephritic syndrome, right? Easy. Now, this line that the patient did not improve for the next 3 weeks and his creatinine increased. So, students thought that now PSGN has progressed to RPGN, rapidly progressive glomerulonephritis. It is a possibility because they are saying the patient did not respond to treatment and the creatinine increased, right? Now, they asked what is the electron microscopic finding in this case, right? Tell me, what is the electron microscopic finding in PSGN? Come on. You all know, I told you, the electron microscopy in PSGN is subepithelial harms due to immune complex deposition, right? So, according to me, the answer is simple. It has to be subepithelial deposits, right? Few students said that, ma'am, we marked crescents because we thought it is RPGN, right? Beta, even if it is RPGN, crescent is not seen on electron microscopy. See the question carefully. They have asked you what is the electron microscopic finding. You don't see crescent on electron microscopy. We see crescent on light microscopy, right? Please read the question carefully. Therefore, the answer here was subepithelial deposit because crescent is seen on light microscopy. Correct? Easy story. So, this was a very good clinico-pathologic question which the examiner asked. Few students got confused, but because they have asked you electron microscopy, the answer here is subepithelial deposits. Easy? Few points about PSGN, let's quickly revise. It's a type 3 hypersensitivity reaction, age 5 to 15 years. There can be a history of streptococcal sore throat which is also given in a clinico-pathologic stem. Clinically, cola-colored urine is seen. On light microscopy, it shows enlarged hypercellular glomeruli. On electron microscopy, we see subepithelial harms because of immune complexes. On IF, there is a lumpy, bumpy appearance. Easy? Let's move to the next one. Okay, a young boy presents with large retroperitoneal hemorrhage. He also gives frequent history of intermittent swelling of knees on strenuous exercise. There was no mucosal bleeding. The catch and a very important point is there was no mucosal bleeding. It is due to deficiency of a fairly easy question, students. My patient has got major bleeding. Remember, I told you two categories. There is a bleeding disorder and there is a coagulation defect. If my patient has defect in platelet, right, or there is a bleeding disorder, what will happen, students? The patient will have minor bleeding, mucosal bleeding. So, here in this question, I have excluded that the patient does not have a bleeding disorder. He has a coagulation defect because my patient has bleeding in the knees, hemorrhage, right? So, patient has hemarthrosis. What is a very common cause of hemarthrosis, students? Factor 8 and 9 deficiency, right? So, answer here was factor 8 and 9. Let us see the other options. Factor 11 and 12, not at all. Von Willebrand factor. I exclude von Willebrand factor because in this question it is given there was no mucosal bleeding. If my patient has von Willebrand's disease, there will be mucosal bleeding, right? So this is not the answer. Lupus anticoagulant, can that be the answer? No, because lupus anticoagulant, students, is also commonly seen in women. There is a history of recurrent abortions, right? So this is also not the case. So the answer here is factor 8 and 9. Fairly a simple question, right? Let's move to the next one. A male child is found to have a swelling in the jaw. A child with a jaw swelling. Always mark the key words in a clinico-pathologic question, right? Biopsy is shown below and the patient had T8:14. What is the diagnosis? I'm sorry, this is supposedly the biopsy image, right? So, what is the most likely diagnosis? Such a easy question, students. Even if you are sleeping, you have to know this topic. This is one of the examiner's favorite topic which has been asked for the past 5 years, and the topic is Burkitt's lymphoma. What is the diagnosis? The diagnosis is Burkitt lymphoma. A child with a jaw swelling with T8:14 translocation. Think about Burkitt lymphoma. Let us quickly revise Burkitt lymphoma. The image, students, it shows a starry sky appearance, right? What do you mean by starry sky appearance? See, in this image, can you people appreciate a lot of this blue background composed of lymphocytes, right? So that is basically the sky. And in between, students, can you people see a lot of histiocytes, right? Macrophages are there. They look like as if in a blue sky, stars are blinking. That is why this appearance is called a starry sky appearance. A lot of time they will give you this image. Once they asked you starry sky appearance is associated with, they asked you the translocation, the answer was T8:14. Also they can give you CMYC because this translocation leads to the amplification of MYC oncogene. Which MYC? C-MYC, right? So the other points in a clinico-pathologic question can be a history of EBV infection. The site is usually jaw or mandible. Right, there is another category of Burkitt lymphoma which is called as endemic. In that, a very important site is the ileocecum or the peritoneum, right? So, GIT can be another site which can be given. T8:14 or CMYC, and the marker is BCL6 positive, a very important and high yield topic, right? So, this is another image of starry sky appearance. Students, I have already told you, and this was the question which was asked last year in INICT. I want to quickly revise this. A boy presents with fever, night sweats, weight loss for 2 months. Ultrasound of the abdomen showed the enlargement of para-aortic lymph nodes. Biopsy of the mass showed a starry sky appearance, right? So, see the history of a boy with fever and night sweats, that is B symptoms. Enlarged para-aortic lymph nodes, I had told you GIT can be another history. And a starry sky appearance. I make a diagnosis of Burkitt lymphoma. The genetic abnormality which is seen is translocation of 8:14 CMYC, right? T922 is seen in CML. Mutation of RB can be seen in retinoblastoma, or it can be seen in osteosarcoma, and P53 mutation is seen in Lee-Fromeny syndrome. Correct? Easy question, students. So, this was a fairly easy one. Next question. In breast cancer, which of the following has good prognosis, right? Very easy question, students, right? ER positive, BRCA positive, P53 and Ki67 positive. Is ER positivity a good prognosis? Remember, I told you luminal A is ER-PR positive and it has a good prognosis. Luminal B is ER-PR positive, also has a good prognosis. But the basal like is ER-PR negative, that has a poor prognosis, right? So here, which has a good prognosis? The answer is ER positive. Is BRCA positivity good prognostic factor? No. BRCA positivity is usually a bad prognostic factor. P53 is a bad prognostic factor, and Ki67, students, is a proliferation index. So, the more the Ki67, the more the proliferation index, the poorer is the prognosis. So, this was a fairly easy question. ER positivity is associated with good prognosis because you can start the patient on hormonal treatment in the form of tamoxifen. Easy? Next. picture of crumpled tissue paper appearance, the enzyme deficiency was asked, right? So, a lot of students told me that a picture with the crumpled tissue paper appearance was given like this, and they asked you the enzyme deficiency, right? A fairly important topic, students, which is asked a lot of times, that is Gaucher's disease, right? So, what is the enzyme deficiency in Gaucher's disease? It is glucocerebrosidase. So, that is why this was the answer, glucocerebrosidase, right? There was a similar question in the last year 2022 INI-CT exam. A child with neurological problems, the bone marrow biopsy is given below. What is the most likely diagnosis, right? Again, this was the question. The bone marrow biopsy showed these cells, and these cells have had crumpled tissue paper appearance. So, the answer was Gaucher's disease, right? This was asked in last year INI-CT, a fairly important topic which you have to remember for the INI-CT exam which is upcoming also, correct? Next, a 25-year-old male patient is having low hemoglobin, platelet count was 25,000 and gum bleeding with raised PT and APTTs. My God, so many keywords. A 25-year-old man with low hemoglobin, low platelet count, 25,000. What is the normal platelet count? 1.5 to 4 lakhs. Gum bleeding and increased PT and increased APTT. The peripheral smear is shown below. What is the most likely diagnosis? Okay. In this peripheral smear, can you see this blast which has got some rod-like structures in the cytoplasm, right? So, these are basically OR rods, right? These are basically OR rods, and OR rods are seen in AML, right? You know it is seen in M2, M3, M4, right? 3 options. But here the catch is low platelet count and increased PT and APTT. If I tell you that the PT and APTT is increased, that means the patient is going under DIC. And which type of AML is associated with DIC? The answer is AML-M3. And remember students, I told you that AML-M3 is associated with which translocation? The answer is T15:17, right? That is why the answer is T15:17, a fairly easy question. Some students got confused with this history of gum bleeding. They said, ma'am, gum bleeding was given and gum bleeding is more common in M4 and M5. So, that is why in M4 and M5, because inversion 16 is commonly seen, that is why we marked inversion 16. No students, gum bleeding is a feature of AML per se. It is more commonly associated with M4 and M5, but it is a feature of overall AML. It can be seen in any AML, gum swelling or gum bleeding, right? So, you won't think that this is definitely M4 and M5, right? Understood? See the image. In this image, can you people see this is a blast? How do I know this is a blast? You can see these prominent nucleoli, homogeneous chromatin. And can you see in the cytoplasm a rod-like structure? What is this rod-like structure, students? This is called as a OR rod. And if there is a bunch of OR rod in the cytoplasm, that is called as a Fagot cell. So, OR rods and Fagot cell are more commonly associated with AML-M3. A lot of points about AML-M3 can be asked, students. What are the points which can be there? One, it is associated with T15:17, associated with DIC, then commonly associated with chloroma is AML-M2, right? Then a very good prognosis is given, is seen in AML-M3. What is the treatment for AML-M3 which was asked in last year INI-CT May exam? The treatment is all trans-retinoic acid or ATRA, right? So, these are few important MCQs which can be asked from AML-M3 which you need to know, correct? Let us move to the next question. A 4-year-old child presents with intermittent jaundice and splenomegaly. There is a history of similar complaints in the elder brother. Peripheral smear shows the following. How will you investigate the condition, right? Now, see the peripheral smear, students. What can you people see? Can you people see that there are these cells which do not have a central space, right? There is no central pallor and they are smaller and totally round, right? So these cells, these RBCs which I can see, they are mostly spherocytes, right? That is why students, spherocytes are seen in which all conditions? I know they are seen in hereditary spherocytosis, autoimmune hemolytic anemia, burns and blood transfusion reactions, right? Now here these two are not the answers. So what we are left with spherocytosis and AIHA, right? What is the most common cause of spherocytes? AIHA is the most common cause, right? Now in spherocytosis you will do osmotic fragility test. In AIHA you will do which test? Coombs test, right? Now a lot of students got confused between these two options which were there, right? Important point here students is the history of a child. It is a 4-year-old child and there are similar complaints in elder brother, right? There are similar complaints in elder brother. That means the disease is genetic. So my answer goes towards which diagnosis, which disease? Hereditary spherocytosis, right? So the answer in this question is osmotic fragility test and hereditary spherocytosis, not AIHA. Why? Because there was a history in elder brother which was given and there was a history of a 4-year-old child. AIHA would usually present at a middle age, maybe 15-20s, and there will be no hereditary history because it's not a hereditary disorder. Understood? Why am I marking hereditary spherocytosis in this case? Right? Very good clinico-pathologic question. Correct? Next. A patient with creatinine of 4.5 milligram per deciliter was positive for hepatitis B. The kidney biopsy shows glomerulonephritis with spike and dome pattern, right? Which type of glomerulonephritis this patient is suffering from? This is one of the easiest questions from kidney which they could make, because remember students, I told you spike and dome pattern is seen in where? Which disease? The answer is membranous glomerulonephritis. That is why this is the answer, membranous spike and dome pattern. Easy. So kidney, we have done PSGN, cola colored urine, child, type 3 hypersensitivity reaction, subepithelial humps. And there was this question on spike and dome pattern which is seen in membranous glomerulonephritis. Easy. This was a fairly easy and straightforward question. Next. Which of the following is true regarding Mendelian modes of inheritance? This was one question which was a bouncer. 2/3 of Mendelian disorders are autosomal dominant. 1/3 of Mendelian disorder is autosomal recessive. Every 5th patient is X-linked recessive. Every 10th patient is Y-linked, right? Now students, Robbins does not give an answer. It is a totally factual question. There is no line in Robbins which gives the answer to this question. We searched in Harrison. There is a line which says that every 10th patient is Y-linked. That is why this is the most likely answer, right? But a very factual question. This was a bouncer which, some of you might have got it correctly by chance, right? Next question. A 60-year-old male had very high TLC. Peripheral smear is shown below. What is the next step in management? Now, this is the most recent trend with the examiner students. They ask about the next steps in management, right? A lot of times, like once there was a question on chloroma and they have asked you what is the next test which you will do, right? Which are very good questions because they test your clinical knowledge as well as pathological knowledge. Now, in such questions, first of all, you have to make a diagnosis. My patient is an elderly patient, right, with TLC which is very high, a peripheral smear showing lymphocytes. Can you people appreciate these cells? These are the normal lymphocytes, right? And a very important thing is these cells, students. What are these cells? Can you people appreciate that these cells are basically the smudge cells? Can you see their boundaries which are smudged, right? So these are the smudge cells. Now high TLC with lymphocytosis and smudge cells is seen in CLL. What is the diagnosis which you make? The diagnosis is chronic lymphocytic leukemia. Easy diagnosis. Now, what is the next step in management? Bone marrow biopsy. Do you do a bone marrow biopsy? You do a bone marrow biopsy, but it is not important for diagnosis. It is important only for prognostic purposes in case of CLL, right? So, that cannot be the answer. Start high dose chemo. Without doing the markers, you cannot start high dose chemo, so not the answer. Flow cytometry. Yes, that's the answer. Flow cytometry. Why? Because remember, students, I told you for CLL, we usually make a diagnosis by these two markers. The cells are CD5 positive and 23 positive. A very important point. The markers are very important for diagnosis. That is why what you have to do, students, is flow cytometry, right? So, very good question, students. You have to do markers, so you will do flow cytometry. That is the next step, right? CLL, again a clinical question on CLL, has been one of the examiner's favorite for the last 3 years, right? Okay, what are the important points? Elderly, usually age is 60 to 70 years. Pathology, there is deletion of 13q, 11q or 17p, another very important point. Patient usually has painless lymphadenopathy. An extra point is the patient can have a history of autoimmune hemolytic anemia. There is absolute lymphocytosis more than 5000 per millimeter cube. The peripheral smear will show smudge cells, also called as parachute cells, also called as basket cells. The biopsy will show proliferation centers, and the markers are CD5 positive, 23 positive and CD200 positive, right? This was a question which was asked in the INI-CET exam last year. The given peripheral smear is associated with which leukemia? There were lymphocytes, there was smudge cell. I came to a diagnosis that the answer was CLL. What will you see on AML? I will see myeloblast. Can you people see myeloblast in this case? No. In CML, what will you see? I will see basophilia on peripheral smear along with all stages of myeloid maturation. All different stages of myeloid maturation. And in ALL, I will see a lot of lymphoblasts. So, that is also not the answer. Easy? This was also the question, students, which was asked in the INI-CET exam last year. 65-year-old male patient with fatigue, lymphadenopathy presents to the OPD. Peripheral blood smear shows the presence of smudge cells. Which of the following additional investigations will you do to arrive at a diagnosis? Similar question was asked in this year NEET, right? Flow cytometry, cytogenetics, fish or bone marrow? The answer is flow cytometry for CD5 and 23 markers. Both of these markers are positive. Easy? Next. Again, this is the image, lymphocytes, and these cells which have an arrow, these are the smudge cells. Next question. A 5-year-old child comes with fever, fatigue and left ventricular dysfunction. Cardiac biopsy image was given. What is the most likely diagnosis? So, this is a bit controversial, students, because I don't know what the exact image was which was given, right? The history of a child with left ventricular dysfunction, fever and a biopsy. Now, if the biopsy was showing something like this, students, like something like this, then these are basically Ashkoff bodies, right? Something like this also, these are basically Ashkoff bodies. But I don't know what was the image because different students gave me different images, right? Now, if the biopsy was something like this, I would mark the answer as acute rheumatic fever, right? But a lot of students said that, ma'am, there was an image with cardiac myocytes with a lot of lymphocytes. Then you will mark the answer as lymphocytic myocarditis. Now, this is still controversial. A child with left ventricular dysfunction with the biopsy showing maybe Ashkoff body or Anishkoff cell, you will mark the answer as acute rheumatic fever, goes in favor of that. But if the biopsy only had a lot of lymphocytes, you will mark as lymphocytic myocarditis, right? Let us quickly see. This was a question in last year's INI-CET exam. A patient came to the outpatient department from complaints of dyspnea on exertion for 1 month. Echocardiography showed the presence of mitral stenosis. Identify the histopathological examination image given below and what is the probable diagnosis. Now, with this history of mitral insufficiency and a biopsy which was showing a body like this was Ashkoff nodule and the diagnosis was rheumatic heart disease, right? This was last year, right? So, you have to know what are the important points of rheumatic heart disease on pathology, very commonly asked. One is Ashkoff bodies, right? Another is Anishkoff cells. Now, these Anishkoff cells, they have a slender wavy ribbon-like nuclei. That is why they are called as caterpillar cells. Other important thing is bread and butter pericarditis or buttonhole stenosis or a McCollum plaque or a subendocardial jet. Easy? Yeah. The next one. A 5-year-old child with bleeding per rectum, the rectal polyp greater than 5 mm on histology shows enlarged inflammatory glands with mucin. What is the most likely diagnosis? Now, this was a very good question because this was a bit tricky, right? Again, students, I am repeating once again, polyps are one of the examiner's favorite topic. Hematomatous polyp, adenoma carcinoma sequence, adenomatous polyp and Peutz-Jeghers syndrome. 4 very, very important topics from GIT, right? Every year these days they are something or the other about polyps. So, please do it in detail for INI-CET exam also. Now, let's come to this question. There was a child with bleeding per rectum and a rectal polyp. What kind of a polyp usually do you see in children with bleeding per rectum? That means their rectum is a site. It is called as a juvenile polyp. Easy? You have made a diagnosis. And what kind of a polyp is juvenile polyp? It is a hematomatous polyp. That is why the answer which I will write here is a hematoma. That is the answer. This is a hematomatous polyp. Such a simple thing, right? You people complicated. And look at the other options. Choriostoma is definitely not the answer. Will you think of carcinoma in a child? I will never think of carcinoma in a child, and when there is no other history which is given, right? Adenoma again. This is not an adenoma because this is a child. Juvenile rectal polyp is a type of a hematomatous polyp. That is why the answer is a hematoma, right? Let us quickly revise Peutz-Jeghers syndrome because this is also one of the important topics which is asked. Autosomal dominant. Pathologically, it is associated with LKB1 or STK11 gene mutation. Clinically, there are multiple hematomatous polyps. Perioral melanosis, so there can be a picture of that also. Mucocutaneous hyperpigmentation. There is an increased risk of pancreatic cancer, breast cancer, thyroid or colon cancers, right? Very important is the image, histopathological image, because on biopsy it shows a arborizing pattern of smooth muscle mixed with lamina propria, and this appearance is called as a Christmas tree appearance, right? So there is a arborizing pattern, something like this. It looks like a Christmas tree. Easy? Next. A child with hepatosplenomegaly, petechial rashes and owl's eye appearance. Which organism is seen in the urine cytology, right? Very easy question, students. Remember, I have told you 2 owl's eye in pathology. 2 owl's eye are basically the Reed-Sternberg cell, which is seen in Hodgkin's lymphoma and cytomegalovirus infection. Here it was one infection. The answer was CMV. Easy? Right? So, owl's eye, that means cytomegalovirus. So, both these things you have to remember, students. Regarding owl's eye, CMV you should know in detail, and you should know the other owl's eye, Hodgkin's lymphoma. Till now, for the past 3 or 4 years, the examiner's favorite topic, whether it is INI-CET or NEET or FMG, has been Hodgkin's lymphoma and Reed-Sternberg cell and that owl's eye. This year, they changed the topic to CMV owl's eye, right? So, 2 owl's eye in pathology. Large cells which are binucleate with prominent eosinophilic macronucleoli, that is called as the owl's eye appearance, seen in Reed-Sternberg cell and Hodgkin's lymphoma or cytomegalovirus infection, right? So, that is why, students, please do Hodgkin's lymphoma in detail also for all your future exams, right? Understood? Okay. Let us move to the next question. Identify the following histological image, right? This was an easy one this time, right? They gave such an image. When you see such an image, can you people identify that this looks like a glomerulus and these are the tubules around it, right? So, this was a fairly simple one in which the answer was a glomerulus. What is this histological image? This is a glomerulus, right? Next. So, when I see the kidney biopsy, students, these are the glomeruli which you see, right? Remember I told you these are the glomeruli. and these are the tubules which you see. You also see the interstitium, that is the space in between them. Easy? Next question. A patient was transfused 4 units of blood 2 hours ago. Now she complains of chest discomfort. The X-ray shows fissural thickening. It is due to, the answer is, students, fluid overload, right? Now, a patient with blood transfusion, within 6 hours, if something is developing, right, it can be some respiratory thing is developing, it can be either TRALI, transfusion associated acute lung injury, or it can be TACO, right, either TRALI or TACO. Transfusion related acute lung injury will also develop after blood transfusion. Within the first 6 hours, the patient will complain of respiratory problems. The X-ray in this case will show a white out appearance, right? And in TACO, students, this is basically due to circulatory overload because a lot of blood is transfused within a short span. Here 4 units within 2 hours, a lot of blood, right? So, best answer here is fluid overload. And in TACO, students, the patient's blood pressure also rises. Easy? Very important topic for all MCQ exams, correct? Next. A chronic smoker who worked in a cement factory for 20 years developed mesothelioma. It is due to, very easy question, but you people complicated because you people messaged me that ma'am, cement factory was given. Okay, now cement factory can lead to silicosis, right? It can also lead to asbestosis, right? So, some students I think marked silicosis. Beta, the important point here is mesothelioma. Silicosis cannot lead to mesothelioma. If it is mesothelioma, the answer has to be asbestosis. So, here there was a direct answer, asbestosis. Again, a very important and commonly asked topic. Students, repeatedly it has been asked, asbestosis. Usually there is a history of a construction worker or a shipping industry. Usually affects the lower lobe of the lung. There are 2 types of fibers, serpentine and amphibole. Amphibole are the more pathogenic fibers which are seen. The earliest or the most common lesion is the pleural plaque, and the most common type of malignancy is a lung cancer, while the most specific malignancy is a malignant mesothelioma, correct? Then students, another thing which they have asked repeatedly from asbestosis is asbestos bodies, right? They are dumbbell shaped beaded fusiform rod like structures. They are called asbestos bodies or ferruginous bodies. This image has also been given in the MCQ exams previously, you have to remember. Can you see these bodies? Dumbbell like, they look like dumbbells, right? Beaded fusiform rod like structures, right? Now, these bodies, because they are asbestos fibers coated with iron, that is why students, they are Prussian blue positive. Now, this can be asked in the future exams, right? So, this students is the image which can be asked in the future exam. These are the pleural plaques which are usually seen because of asbestosis. And this is the last thing, that is, this is the NICT MCQ which was asked last year. A person working in an industry long term developed progressive breathlessness and pleural thickening. His histopathological image is given below. Now, pleural thickening with this kind of image, what will you think of? Asbestosis. So, the person was working in an asbestos industry, right? So, these are the questions which were asked in this year 2023 NEET-PG pathology, students. Fairly easy questions, but I would still say that for answering such kind of clinical questions, you need to have your basics correct, and revisions are very, very important, right? So, students, please keep revising because revision is the key to crack all the MCQ exams. You can only solve clinical questions if you revise your course thoroughly, right? All the basic concepts should be clear. The good part about pathology in NEET 2023 was all the questions were from the repeat topics, the important topics, right? Lastly, I would just like to say, students, you still have 2 months for your NICT exam. So, do not procrastinate. We have this habit that, okay, I will do this later on, or this is my weaker subject, I'll do this later on. No, do not procrastinate, because ultimately it can be too late also, right? Start doing from now, start revising, right? Thank you so much everyone, and all the best.